therapy, non-pharmacological treatment of osteoarthritis, and the difference between rheumatoid arthritis and osteoarthritis. So we will discuss a case. A 65-year-old lady comes to the OPD. She has a history of diabetes mellitus, hypertension, and dyslipidemia for more than 10 years. She came into the outpatient department with the chief complaint of the left knee pain. Complaint of the knee pain is for 2 to 3 weeks, and there is no other previous history of knee pains. Pain was localized on the anterior aspect of the knee joint. No history of trauma or sprain. Walking and climbing the stairs aggravated the pain. The pain was relieved by resting. The knee pain had affected her daily activities, and it was difficult for her to climb up and was walking with a limp. No other joint pains were reported. There was no reporting of locking or popping sounds in the knee joint. She noted that the left knee was mildly swollen in comparison to the right knee. Morning stiffness of both the knees were reported, and the duration of the stiffness was for 15 minutes, and it disappeared as she began the activities. There was no fever, loss of weight, or loss of appetite. So the pain was only localized, and there were no generalized symptoms with her. She had no history of knee injury or surgery, no history of gout, rheumatoid arthritis, or degenerative joint disease. She also has no family history of gout. Drug allergies were nil. The general physical examination was normal. She was walking with a stable gait. She was a well-nourished lady with a BP of 140/90. Respiratory, cardiovascular, and per abdominal examinations were unremarkable. Knee examination showed no erythema, bruising, or discoloration of the left knee. There was also no point of tenderness. Slight bulging was seen in the medial aspect of the knee joint. Popliteal bulging was noted at the left knee joint at the posterior aspect. Musculature of both knees seemed symmetric bilaterally. There was no bone deformity. On palpation, the left knee joint was not warm nor tender, but there was mild diffusion felt. Range of movement was restricted, and crepitus on both legs were felt. So what would be the probable diagnosis? It will be osteoarthritis, acute exacerbation of the left knee joint. Osteoarthritis occurs when the protective cartilage on the ends of the bones of the joints wear down over time. Although osteoarthritis can damage any joint in your body, but the most commonly joints which are affected are the larger joints first, that is the knee, hip, and then later on the spine and the hands are involved. The repair mechanism of tissue absorption and synthesis get out of balance and results in osteophyte formation, bone spurs, and bone cysts. Osteoarthritis is a disease of the joints that affects all of the weight-bearing components of the joint, that is articular cartilage, menisci, and the bone. Synovial fluid leaks into the cracks which can form in the bone surface when this replacement cartilage wears out. This causes further damage and in some cases can lead to the cyst formation or deformities in the bones. Now you can see a normal joint and you can see an osteoarthritic joint. In the osteoarthritic joint, the joint capsule becomes thickened. There is inflammation of the synovial membrane, early degeneration of the articular cartilage tap of osteophytes, bones of osteophytes are seen, fibrillated cartilage, altered bone turnover, that is sclerosis on the radiograph is seen. Two major types of osteoarthritis are there, primary or idiopathic, in which most common type is diagnosed when there is no known cause for the symptoms. And secondary is due to any kind of trauma or accident or any underlying joint disorder. The main symptoms are pain, tenderness, stiffness of the joint, loss of flexibility, that is, the range of motion is reduced, grating sensation in the joint, and bone spurs are formed. Risk factors which you cannot change are the family history of the disease, increasing advancing age, and being female. The risk factors which you can change are overuse of the joint, major injury which can be prevented. You can lose the weight, that is, it is more common in overweight individuals, and muscle weakness. Muscle weakness can be overcome by doing different exercises for the knee joint. Now, the laboratory investigations for osteoarthritis, since it is not a systemic disorder, it is a localized degenerative disorder, we will just go for the CBC and ESR and C-reactive protein. C-reactive protein is basically a marker of inflammation. Joint X-ray will be formed. Synovial fluid examination can be done, which can show mild leukocytosis. It can be used to exclude the septic arthritis if the diagnosis is in doubt. In X-ray, we can see the cartilage loss by narrowing of the space between the bones in the joint. An X-ray may also show some bone spurs around the joint. Some people may have X-ray evidence of osteoarthritis even before they experience any kind of pain or any kind of symptoms. So the X-ray shows asymmetrical joint space narrowing from the loss of the articular cartilage. See, you can see the narrowing of the joint spaces. The medial side part of the knee is most commonly affected by osteoarthritis. Management of osteoarthritis is done by acetaminophen, non-steroidal anti-inflammatory drugs, exercise, weight loss, use of heat and cold packs to manage the pain locally. Now, a non-pharmacological management is weight loss, injury prevention, exercise, proper education to the patient. Pharmacological treatment includes oral drugs are acetaminophen, non-steroidal anti-inflammatory drugs, opioid analgesics. If the pain is not controlled with non-steroidal anti-inflammatory drugs, we can also use duloxetine, which is a selective serotonin reuptake inhibitor. Basically, it is an antidepressant, but in studies, it has been found that use of duloxetine decreases the pain in osteoarthritic and rheumatoid arthritic patients or any kind of pain, chronic pain associated with any kind of diseases. So it is now used as an additional therapy along with the painkillers. The topical drugs which we can use are topical non-steroidal anti-inflammatory creams, lidocaine patches can be used, and capsicum local ointment can also be used. Then there are injectable therapies in which we have intra-articular corticosteroids, in which the steroids are injected right into the joint cavity, and intra-articular hyaluronic acid is also injected. But these injectable therapies are done many years later after the patient is not responding to the oral medication. Then we also add on to the glucosamine and chondroitin sulfate to the patients along with the painkillers. So the pharmacological therapy includes acetaminophen. It is an analgesic and antipyretic agent. It lacks the anti-inflammatory or anti-platelet effects. Acetaminophen is useful as an aspirin substitute, especially in children with viral infections or in an individual with any type of aspirin intolerance. Pharmacokinetics, extensive first part metabolism. When taken in large doses, metabolites like N-acetyl P-benzoquinoamine are formed in the liver, which can cause liver toxicity and liver damage in long-term use. It is well absorbed orally, metabolized in the liver, Its half-life is 2 to 3 hours in persons with normal hepatic functions. It is unaffected by any kind of renal disease. So it can be taken in patients with renal failure, but it is contraindicated in patients with hepatic impairment. It is well tolerated, but it is dangerous if taken in high doses. It can cause hepatic damage. So the classification, basically non-steroidal anti-inflammatory drugs have got non-selective inhibition and selective COX-2 inhibitors, which include celecoxib and rifacoxib. The non-selective ones are acetic acid derivative, which includes indomethacin and etoleukinate and difluronate. Propionic acid derivatives include ibuprofen, ketoprofen, naproxen. Then we have salicylates like aspirin and salicylates. Now, whenever there is an injury or inflammatory tissue is activated, the prostaglandins are released and the autopoids are released, which activates the pain receptors and produces the pain. So prostaglandins directly stimulate the pain receptors and increase the sensitivity of the pain receptor to bradykinin and to produce the pain. Non-steroidal anti-inflammatory drugs relieve pain via inhibition of the prostaglandin biosynthesis. Non-steroidal anti-inflammatory drugs are a group of agents that differ in their antipyretic, analgesic, and anti-inflammatory activity. They act primarily by inhibiting the cyclooxygenase enzymes that catalyze the first step in the synthesis of prostaglandins. This leads to decreased prostaglandin synthesis. The major effects are the anti-inflammatory action by inhibiting the prostaglandin synthesis. The analgesic action is produced by specifically binding or inhibiting the prostaglandin E2 synthesis, which is responsible for sensitizing nerves to the action of pain mediators like bradykinin, histamine, and leukotrienes. Antipyretic action by reducing the prostaglandin E2 synthesis, which is responsible for the release of pyrogens from WBCs, which act on the anterior hypothalamic thermoregulatory center. Absorption per oral, it is absorbed rapidly from the stomach, but mostly from the small intestine. Salicylates are distributed throughout most of the body tissues. The drug readily crosses the placental barrier. The biotransformation of salicylate takes place in many tissues, but particularly in the hepatic endoplasmic reticulum and the mitochondria. The adverse effects are nausea, vomiting, epigastric discomfort. On long-term use, they cause peptic ulceration. Renal damage, especially if there is any pre-existing renal disease. Otherwise, it does not cause renal damage. It causes hepatic damage. Non-selective, non-steroidal anti-inflammatory drugs are ibuprofen, indomethacin, naproxen, diflucan, and flurprofen. Mechanism of action: inhibition of cyclooxygenase 1 and 2, the enzyme responsible for the biosynthesis of the prostaglandins and certain related autopoids. This results in decreased prostaglandins and thromboxane synthesis. Effect on the gastrointestinal tract: prostaglandin G1-2. Basically, inhibition causes increased gastric acid secretion, which leads to gastric ulceration in the long-term use. Inhibition of prostaglandin E2 decreases the mucus production. Effects on the platelets: inhibition of thromboxane A2 inhibits the platelet aggregation. Adverse effects are nausea, vomiting, epigastric discomfort or ulceration. Reye's syndrome in children with the use of aspirin, because it is contraindicated in children. On blood, it prolongs the bleeding time and thrombocytopenia. Hypersensitivity reaction can take place like urticaria and bronchospasm. In respiratory system, asthma exacerbation and respiratory depression. So if aspirin is given to children, it results in Reye's syndrome, in which there is encephalopathy, progressive seizures, fixed and dilated pupil respiratory arrest, hepatic fatty infiltration. Now, capsicum. Basically, this is a naturally occurring alkaloid derived from chilies. The mechanism of action, capsicum is thought to produce analgesia by depleting the substance P in small fiber receptor neurons on which the transient receptor potential action channel. Subfamily 5, type 1 TRPV1 is predominantly located. It binds to the vanilloid receptor TRPV1, which acts as a molecular integrator of the chemical and physical painful stimuli. Capsicum is currently available as a topical cream preparation, and the recommended dosing is the application 2 to 4 times daily on the affected area. Parenteral capsicum preparations are not available currently. It is used for chronic pain conditions. It is used as a gastroprotective agent. It is used in overactive bladder, and it is also used in post-operative nausea and vomiting. The only side effects are local irritation and sometimes cough. Intraarticular injections, basically we use corticosteroids for intraarticular, we put it directly into the joint spaces, which improves the function and provides only short-term pain relief for around 6 to 8 months. But overall, they do not improve the quality of life of a patient. Hyaluronic acid injections could be effective for osteoarthritis. According to a review of the highest quality studies, it is still under clinical trial. Glucosamine, it is the amino sugar that serves as a precursor of nitrogen-containing sugars, including the glucosamine glycans, that are major constituents of the connective tissue, including the cartilage in the joints. It is primarily used for the pain associated with osteoarthritis and also rheumatoid arthritis. Toxicity, it can occasionally cause diarrhea and nausea, but otherwise it is well tolerated. Chondroitin sulfate, it is a sulfated glucosamine glycan. Basically, we use glucosamine and chondroitin sulfate combination in one tablet, which is given to the patient of osteoarthritis. Chondroitin sulfate is an important structural component of the cartilage and provides much of its resistance to compression. Along with glucosamine, chondroitin sulfate has become widely used dietary supplement for the patients of osteoarthritis. The effect of chondroitin sulfate in people with osteoarthritis is likely the result of a number of reactions, including its anti-inflammatory activity, stimulation of the synthesis of proteoglycans and hyaluronic acid, and the decrease in the catabolic activity of the chondrocytes. So along with the non-steroidal anti-inflammatory drugs, we also now recommend the use of chondroitin sulfate and glucosamine above the age of 50 years in osteoarthritic patients. Now we come to the non-pharmacological treatment. The major thing which we have to tell the patient is basically patient education, self-management programs, weight loss, because weight causes excessive damage to the weight-bearing joints, especially the knee joints, range of movement exercises in order to have muscle strengthening. Assistive devices should be provided to the patient in order to prevent the fall. Appropriate footwear is very, very important for the patients. That actually decreases half of the pain. Lateral wedges insole can be provided to the patients. Joint protection by the use of kneecaps. Surgical therapy is joint replacement and arthroscopic meniscectomy. Now, there are certain differences between rheumatoid arthritis and osteoarthritis. You have already studied rheumatoid arthritis yesterday. And if we just summarize rheumatoid arthritis, basically it is an autoimmune condition. Rheumatoid arthritis is an autoimmune condition and it begins any time in life. That is, it can happen even in young age. Whereas osteoarthritis is a degenerative joint disease and it only occurs later in life, that is above the age of 50 years. In rheumatoid arthritis, the speed of onset is very rapid over weeks to months, whereas osteoarthritis takes several years to develop. The joint symptoms for rheumatoid arthritis are painful, swollen, and stiff, red, tender joints, whereas the joint pain in osteoarthritis is less tender and there is no swelling. The pattern of joint involved basically in the rheumatoid arthritis, the smaller joints are involved first, and later on it comes on to the larger joints, and the involvement for joints is symmetrical. That is, both sides, left and right sides of the joints will be involved. Whereas in osteoarthritis, the symptoms begin gradually and they are often limited to the larger joints and they are non-symmetrical. That is, one side of the knee will be affected and the other side will be normal. The duration of morning stiffness lasts longer than an hour in rheumatoid arthritis, whereas in osteoarthritis, the morning stiffness lasts for less than an hour. In rheumatoid arthritis, we can see the many other symptoms along with the swollen joints like fatigue and fever, whereas in osteoarthritis, there is no fatigue and no fever. Now, there are certain foods which help in the development of connective tissues, which we can advise the patient along with the drug therapy. Bone broth, which is best for the connective tissue and joints. It is rich in collagen. Bone broth also contains a slew of other joint healthy ingredients like glucosamine and chondroitin sulfates, as well as it is rich in calcium, magnesium, and phosphorus. Sulfate containing veggies like broccoli, cauliflower, garlic, cabbage, and onions. They are rich in sulfate, which combine with chondroitin to form a cartilage. It is also required for the process of sulfation to produce glucosamine sulfate and chondroitin sulfate, both of which help in the cartilage production and repair. Bioflavonoids, basically blueberries, all kinds of berries and cherries contain bioflavonoids, along with cinnamon, acai berries, and onions. They contain anthocyanins, which help strengthen the connective tissue by forming a particular link between the collagen fibers. Zinc-containing foods are also very good, which are lamb and sesame seeds and pumpkin seeds, which are high in zinc, which are required for the production of the connective tissue. Copper-containing foods are also very good for the maturation of collagen. Non-pharmacological therapy is important in the prevention and treatment of osteoarthritis. The best studied and most effective non-pharmacological therapy is the exercise, because exercise helps control the weight, it increases the strength, improves the muscle function, and decreases the pain. The traditional belief in our patient is that patients are concerned that the joint use will wear out or damage an already worn out joint, which is very wrong. Which is not true, because moderate intensity exercises basically strengthen the joint. The joint is already worn out when you have osteoarthritis, but you have to prevent the further damage, which can